Evening all. I welcome you all. This is part two of a series called Look Back series at 2020. A few days back, we had a session on ovarian cancer. Today, we are going to have a pancreatic cancer session. And we will have about 2 hour session, starting with few of the lectures. We have a very fiery debate with fiery speakers in it. And then we'll wrap it up with last 30-40 minutes of panel discussion. So without wasting any time, we have an audience seeing this live feed on another platform. And we'll start with a surgeon as usual. In any malignancy, especially GI malignancy, surgeon kickstarts the ball rolling. We have Dr. Dhaval Rajde. He is an excellent GI surgeon, robotic and minimal access cancer surgeon, has an own unit and also works at Sterling Cancer Hospital. And he's going to tell us the very difficult part of a Whipple, especially vascular resection for CA pancreas. Not many surgeons or not many doctors are comfortable with this approach. So let's hear him on this approach. Dr. Dhaval, all yours.
Good evening, friends. Thank you, Viraj. Your zest for academics is commendable. Thanks. Now, today I'm going to speak on role of vascular resection in CA pancreas. I believe that the session is dominated by medical oncologists in terms of attendance. I'm not. The next slide, just a minute. Okay, so I'll start with this first slide and we'll visit this slide again. The key to a good outcome in pancreatic cancer is R0 resection, and then in a borderline resectable cancers, advanced cancers, the multidisciplinary setting. So these two are the key points for good outcome. Now, for pancreatic cancers, only 20% of the pancreatic cancers are operable or resectable when diagnosed. And survival rate for 5 years is 25% for operable pancreatic cancers. And this can go up to 40-50% if you take into account only the R0 resection on the final HP report. So the R0 resection almost doubles the survival rate in pancreatic cancer. And surgery is the only potentially curative treatment option available. So what are we discussing today? Mainly the borderline resectable pancreatic cancer and occasional locally advanced pancreatic cancer. This is a little busy slide defining the resectability taken from NCCN guidelines, which divides these pancreatic cancers into 3: resectable, borderline resectable, and locally advanced. And if we look at borderline resectable, it is usually the arterial solid tumor contact with common hepatic artery or artery bifurcation or contact with SMA less than 180 degree. And at the same time, for venous, the solid tumor contact with the SMV or portal vein more than 180 degree. Less than 180 degree makes it resectable. So next slide we'll see few such images. So now this is one image where the tumor is away from the portal vein, and this is a clearly resectable pancreatic cancer. Here the pancreatic cancer is abutting the superior mesenteric vein more than 180 degree, and this is an example of borderline resectable pancreatic cancer. And then here is a case where the tumor is encasing the portal vein, superior mesenteric vein as well as superior mesenteric artery, and this is a locally advanced pancreatic cancer. So this is one slide I am discussing resectable cancer, and when we are dealing with the resectable cancer, even for the resectable cancer with abutment to SMV of less than 180 degree, one has to be prepared for venous resection if the need arises. This is a purely intraoperative decision. It is very difficult to differentiate between tumor-induced desmoplasia and direct infiltration of the perivenous tissue. But then this is a purely intraoperative decision, and one has to remember R0 resection almost doubles the 5-year survival rate. So even in a resectable situation, if during surgery one feels that vein needs to be resected to achieve R0 resection, it is a worthwhile exercise. When we discuss borderline resectable pancreatic cancer, we have to discuss role of neoadjuvant treatment, because that is what has made this whole surgery worthwhile. So the role of neoadjuvant treatment theoretically would be that it should improve R0 resection rate. It gives us the biological waiting period where aggressive biology tumors would progress and we can keep them out of the surgery, and we can treat micrometastasis at the earliest possible time. So role of neoadjuvant therapy in borderline resectable cancer, we have to understand that there is no randomized control trials, there is no high level evidence, but there are enough phase 1 and phase 2 clinical trial data available to suggest that it is effective and safe, and it improves R0 resection rate. And most of the institutions would practice NACT or NACRT for borderline resectable cancer. Now, this is one large meta-analysis by Longpan et al. Published in Journal of Surgical Oncology 2020, where NACT versus upfront surgery was compared. And this is a meta-analysis of 17 trials with 2286 patients. And for borderline resectable pancreatic patients, NACT or NACRT group had higher overall survival regardless of analysis of all patients or resected patients. And this is very important. Even if we take into account all patients, and when we give NACT, almost 40% of patients never get to operation theatre, only 60% gets to operation theatre. But then even when we compare only resected patients, the overall or we compare all patients, the overall survival is better for NACT group. NACT in BRPC had better overall survival, better disease-free survival, lower recurrence rate, and very important, higher R0 resection rate. And the most important slide is similar resection rate. Initially, there was lots of confusion that when we give NACT, the patients don't tolerate them, their performance status goes down and we are not able to operate, but it is actually not so. The data clearly says that the overall resection rate for upfront surgery as well as after NACT is similar. So how do we work up this patient? The pancreatic protocol, CT abdomen pelvis with thorax is very important. Then CA19-9 and PET scan is reserved for only gray areas on CT scan. Usually 2 attempts at biopsy, preferably US guided, because that is the best way to do it. Usually plastic or short metallic stenting for all jaundiced patients undergoing neoadjuvant treatment, and a staging laparoscopy to rule out peritoneal dissemination, particularly in patients with very high CA19-9. Neoadjuvant regimens, I believe that it will be discussed by medical oncologists in great detail in coming talks. So I have kept this slide empty. But usually 2 to 3 months of chemotherapy before the first assessment. And evaluation after neoadjuvant treatment, the most important part. We need to take into account all these 3 things: pancreatic protocol, CT scan, CA19-9, and performance status, well-being, appetite, diet, everything. So how do we evaluate them? This is very important. Neoadjuvant chemotherapy rarely results in radiological regression of tumor. Rather, some amount of perivascular soft tissue increase is common and should not preclude resection. You have to take into account CA19-9 and overall well-being. If the CA19-9 has reduced or has remained stable with the overall well-being being improved, even with the stable radiological picture, this patient should be given a chance of surgery. And this lack of radiological regression is the reason, probable reason, that NACT does not help in locally advanced pancreatic cancer. And that is the reason Dr. Samir is going to talk about SBRT in LAPC. So these are few abbreviations that I've just highlighted. Pancreatic duodenectomy is PD, venous resection VR, and arterial resection AR. Now, this is one a meta-analysis comparing the two surgeries, pancreaticoduodenectomy versus pancreaticoduodenectomy plus venous resection. And these are two major meta-analysis available on in the database. One is by Xiaobo Wang et al. And another is Cheng Peng et al. And when we compare this outcome for both the meta-analysis, the operative time was obviously higher for venous resection. The blood loss was almost the double, 500 ml versus 1000 ml for venous resection. But infection abscess were rates were similar in one trial, little higher on in another study. The fistula rate, that is pancreatic leak rate, was similar in both the studies. The mortality was almost similar in one study, almost the double in another study. And this is very important, the R0 resection rate. The R0 resection rate for vascular resection or venous resection was 60%, little less than the upfront surgery, and we'll discuss the reason for this later. Another important point was 5-year survival for upfront surgery was 25%, and for the vascular resection or venous resection was 15%. The reason for lower 5-year survival is obviously we are dealing with the larger tumors, little advanced tumors when we are doing vascular resection. So the little lower survival is obviously expected. But the most important outcome of the study was that the 5-year survival when R0 resection was achieved, both the surgeries was similar in both the cases, which was around 40% 5-year survival, which is excellent for a little advanced tumor. So the key, that point that is to be highlighted is achieving the R0 resection. The pancreaticoduodenectomy plus venous resection, there was this very important subgroup analysis of patients who had pancreaticoduodenectomy plus venous resection and had positive margins suggest that positive margin is usually at the retroperitoneum and not around the vascular resections. So this is very important. These tumors are usually little larger. The average tumor size in upfront surgery is around 2.5 centimeter, while when venous resection is planned, the average size of tumor is 3.5 to 4 centimeter. And this leads to positive margin at retroperitoneum and not around the vessels. So that is the reason that the R0 resection rate is little lower and the survival is little lower. But otherwise, with venous resection, if we achieve R0 resection, the survival rate is good and equal to upfront surgery. The reconstruction methods usually primary end-to-end anastomosis if there is no tension on the anastomosis, page graft by saphenous vein for lateral venous resection, the left renal vein, and the other option is internal jugular vein, which is my preference as a head and neck surgeon. It is very easy for us to go in neck and retrieve internal jugular vein. So why to give up on left renal vein? This is just an example, and this is not the example of CA head pancreas, because, and this is actually a venous resection done for hilar cholangiocarcinoma, but because I had very good images where all the structures were very well highlighted, I have selected images of this case. This was a case of hilar cholangiocarcinoma where the left portal vein you can see is not opacified. The confluence of right and left portal vein is involved with the tumor, and this patient needs venous resection along with hepatectomy. So this is what was done. The right portal vein, the main portal vein, the confluence, and here is where the tumor is and the confluence is involved. This is the hepatic artery and the right hepatic artery, and the left hepatic artery is ligated. This is the sternum. And then we can see the segment of vein was removed. The right portal vein was anastomosed to the main portal vein, and the left liver was removed. This surgery I had done around 9 years back, and this patient was 35-year-old female, and this patient is cured. The point I am trying to highlight over here is that when you do venous resection and you achieve R0 resection margin for pancreatic cancer or for hilar cholangiocarcinoma, they usually do well. And why am I highlighting this is because I am trying to compare venous resection with the arterial resection, which does not have great outcomes. The this is the same photo of the same. So now we get to the pancreaticoduodenectomy plus arterial resection. This usually is attempted at high volume tertiary care centers only. Once tumor starts infiltrating periarterial neural tissue, even with arterial resection, chances of achieving R0 resection is remote because these tumors have perineural spread and skip metastasis, and it's very difficult to achieve R0. Pancreaticoduodenectomy plus arterial resection gets done for very selective cases at very selective centers and remains investigational at best. Usual vessel resected is common hepatic artery and celiac axis. Reconstruction is usually with the reverse saphenous vein graft. Usually prosthetic grafts are avoided for fear of infection. The PTFE vascular grafts have appeared to be safe in 2 studies and can be used if we are losing a long segment of vessels. One needs to monitor liver vascularity closely during surgery and post-operative period. Personally, I feel that if you really need to get into arterial resection, you should be removing a long segment of artery and replacing it with the PTFE vascular grafts, because that is the only chance you can get R0 resection. And then I will touch upon this rare situation of doing a distal pancreatectomy for body pancreas tumor, where if a proximal body of pancreas is involved, it can be involving celiac axis and then it can be resected. Arterial resection could be done. Here the arterial resection is not very complex in the sense that you can remove celiac axis at its origin and up to the common hepatic artery. If we can preserve gastroduodenal artery and common hepatic artery, we may need not to reconstruct, and liver can get blood supply via GDA with the collaterals. But definitely the ultrasound monitoring of liver vascularity is must. So I will revisit this slide again. The R0 resection is the key point, and achieving R0 resection almost doubles the survival, whether it is resectable cancer, whether it is borderline resectable cancer. And this kind of surgeries are obviously best tackled in a multidisciplinary setting where medical oncologists, surgical oncologists, gastroenterologists, and endoscopists and all radiation oncologists, all specialties are available. So this sums up my talk. I have not gone into great details of into the surgical aspect of this, because I believed that this was going to be dominated by medical oncologists in terms of attendance. Thank you.
Thank you, Dhaval. It was an excellent talk. In fact, we have many surgeons also in the audience. And I know we wanted to run in time, but there is a question, and that is a question, in fact, I wanted to ask. Yeah. So there is a question from audience for you. What is the size of portal vein involvement which you are comfortable with before going ahead for resection? Let's say, how much are you comfortable before resecting it? That's the question from one of the surgeons, I guess. It's a surgical candidate.
Yeah. So the key point when we are considering venous resection is whether the confluence is intact or not. Do we need to resect the confluence or not? SMPV confluence, that is splenoportal confluence. So if the splenoportal confluence is preserved, then the job becomes easier. And the below splenoportal confluence, you can easily resect up to 3 centimeter and achieve primary end-to-end anastomosis. When the splenoportal confluence is involved and we need to resect it, we have to take a call on whether we are doing splenectomy or not, but most of the time you can get away with it. The length that I would say I am comfortable with is around 4 centimeter. I have experience of 2 cases where I have done one lateral venorrhaphy with the patch and one segment resection with a interposition graft with internal jugular vein, which was a small segment around 2.5 centimeter, but I believe up to 4 centimeter, it should be manageable.
Right. So if I understand, I think so it's the residual vein which is left behind, which is more important rather than the what we cut.
So we should have a reconstructable stumps available at upper and lower end.
Great.
Then length of graft is not very important. It is manageable.
Thank you so much, Dhaval bhai. It was an excellent talk. I hope you can stay for the further program because there is a panel discussion and I might pitch in few surgical questions. Thank you so much. All right, moving on, we have my friend and colleague, Dr. Samir Batham. He is a radiation oncologist and specializes in GI oncology in my institute. And he is going to take us through role of SBRT in pancreatic cancer, localized pancreatic cancer, when and how should we use it, in which situations. Samir, all yours.
Thank you, Viraj. So I'm sharing my screen now. Is it on? Can you see my presentation?
Yes, sir, we can see your presentation.
Okay. Yeah, good evening, everyone. So first of all, I would like to thank Viraj for giving me this opportunity. My topic is emerging role of SBRT in locally advanced carcinoma of pancreas. So when we talk about pancreatic tumors, surgery is the only curative treatment, as Dhaval also mentioned in his talk. But unfortunately, most of the patients, when they are diagnosed in either borderline resectable or unresectable stages, where they have to undergo chemotherapy or chemoradiation. Patients who respond and eventually becomes resectable, they finally undergo surgery. So resectability status, as this was briefed by Dhaval, so I will not go into the detail again. Coming on to the treatment paradigm, for majority of the patients who are actually unresectable or borderline resectable, they are left with options of chemotherapy either alone or definitive chemoradiation, chemotherapy followed by chemoradiation, or chemotherapy followed by SBRT. Why we want to give radiation? So the aim is to sterilize the vessel margin, especially when we are giving in neoadjuvant setting. The other aim is to enhance the likelihood of a margin negative resection. We want to provide adequate local control to prevent or delay progression. Sometimes we want to palliate pain and bleeding or relieve obstructive symptoms. Why local control is important? We know most of the patients of pancreatic cancers, they eventually die of metastatic disease. The disease spread very fast in the body. But still there was a study at Hopkins, and this was an autopsy series where they found that up to 30% of the patients, they died of locally destructive disease with few or no distant metastasis, suggesting that a significant population of patients with pancreatic cancer may have prolonged survival if the primary tumor can be sterilized. So that's why local control is very important. So what is SBRT? So according to American College of Radiology and Astro, they defined SBRT as an external beam radiation therapy method used to very precisely deliver a high dose of radiation to an extracranial target within the body using either a single dose or a small number of fractions. There are numerous studies which have compared SBRT with conventionally fractionated radiation, and that too in locally advanced pancreatic cancer. This was one of the study which used National Cancer Database, and what they concluded was that SBRT was associated with a superior overall survival in comparison with the conventionally fractionated radiation in locally advanced pancreatic cancers. Why pancreatic SBRT? Because we know that local control is very important. Chemoradiation in general is very arduous, and SBRT can offer equal or better local control with less acute toxicity and shorter overall treatment duration. So we know chemotherapy is very important part of the therapy for locally advanced LAPC patients. And by SBRT, we can switch them very early to their main treatment, which is chemotherapy or surgery. Coming on to the clinical outcomes of SBRT in CA pancreas. So this was the first study of SBRT in locally advanced pancreatic cancer. This study was published in 2004 in Red Journal. This done at Stanford University. A very small study on 7 patients when CyberKnife just came into existence, and people were very excited to try this modality in whatever diseases or wherever it was possible. They were trying to explore the use, and in this study, they gave 3 different doses: 15 gray, 20 gray, and 25 gray in single fraction. Mind it, this was a single fraction stereotaxy. So all these 7 patients, they had 100% local control rate. All these patients, they died from some distant site or distant failure. The median survival in this group was 11 months. So next year, they published another report. This time, this was a phase 2 study, and this time, this single fraction boost was used after conventional chemoradiation, which was 45 gray IMRT with concurrent 5U. This time, the local control was 94%. Median survival this time was 8.3 months, but obviously, there were more grade 3 GI toxicities. So single and multi-fraction regimes were later tried with finding that multi-fraction regimes had less SBRT related toxicities. This was one of the phase 2 multi-center trial published in Cancer 2014 by Herman et al. 49 patients they received SBRT, but before SBRT they received gemcitabine. And many of these patients, even after SBRT, also they received gemcitabine. SBRT was 33 gray, which was delivered over 5 fractions. 83% local progression-free survival was observed. Median overall survival was 13.9 months. Acute as well as late toxicities were manageable and not that significant. This is to sum up the major studies which have evaluated the role of SBRT in locally advanced pancreatic cancers. In fact, some of the studies, they have included patients with borderline resectable diseases and locally recurrent diseases, different doses, different schedules, different fractionations. Some have used single fractions, some have used 3 fractions, some have used 5 fractions, different local control in different studies, ranging from 50% to up to 100%, median survival ranging from 5.4 to up to 20 months, different chemo regimes. Most of the time it was gemcitabine. So this was a study which was published in Red Journal in 2016. This was a systematic review and pooled analysis of 19 trials of SBRT in locally advanced pancreatic cancer, and what they concluded that or what they observed was a local control at 1 year was almost 72% and a median overall survival of 17 months. What is the rationale for neoadjuvant therapies? Some 25% of the patients, they do not receive adjuvant therapy in time. 20 to 40% of the patients will be spared of the morbidity of resection because their metastatic disease will become clinically apparent. This is the neoadjuvant therapies in general are less toxic and more effective, as chemoradiation would be given without the post-surgical issues of small bowel in the radiation field and decreased oxygenation and decreased drug delivery to the remaining tumor bed. It can downstage the tumor and sometimes make a borderline or unresectable tumor. It can turn into a resectable one. I agree with Dhavalbhai. There are studies which have shown that there is no survival advantage, which he has mentioned, but this is the rationale for the neoadjuvant approach. This is one such study which was published again in Red Journal in 2012. Study was done at Tampa, Florida, in 73 patients. Of these 73, 56 patients had borderline resectable disease. They were treated using dose painting technique. Dose painting is where we try to give a slightly higher dose to the involved to the tumor, which is adherent to the vessel, and slightly lower dose to the remaining tumor. So, and this SBRT was delivered after 3 courses of neoadjuvant chemotherapy with gemcitabine, Taxotere, and Zoloda. Restaging was done after 4 weeks. What they found that patients with significant regression away from the blood vessel in question, they underwent surgery, if possible. So for the subset of patients with borderline resectable tumors, 77% of patients had a treatment response and they underwent an exploratory laparotomy. And finally, 56% of the patients, they ultimately underwent surgical resection. And there was a very high rate, 97% of the patients, they had R0 resection. Complete pathological response rate was also seen in 9% of the patients. So patients who undergo surgical resection had significantly improved survival compared to those who did not. Toxicity was acceptable with only 5% of patients who experienced grade 3 toxicities. So these results provide support for further exploring SBRT as a means of allowing curative resection in patients with borderline resectable diseases. Another paper published this year only in Green Journal. This was a pooled propensity matched analysis of the National Cancer Database. We do not have too many randomized trial as of now, but probably in the coming future we'll be having many randomized trials also to support the role of SBRT in all these situations. But as of now, we are having these kind of data only. So this study also concluded that neoadjuvant chemo with SBRT is associated with favorable survival and pathological outcomes. The study, they studied basically 3 cohorts of patients, one who received chemotherapy alone, the other who received chemotherapy and SBRT, and the third cohort received chemotherapy and conventional fractionated radiation. And clearly they found that chemo and SBRT are associated with better survival. Talking of toxicities of SBRT, in general, SBRT is very safe. It has been proven again and again in many studies. There are almost very less acute side effects, and even late side effects are also very much acceptable. Common side effects include nausea, diarrhea, abdominal pain. Rarely we encounter intestinal obstruction or GI bleeding because of SBRT. There are studies on cost effectiveness of pancreas SBRT. In this study, which was published in 2012, they compared 4 models of gemcitabine alone, gemcit with conventional radiation, gemcit with IMRT, or gemcit with SBRT, and they concluded that gemcit SBRT increases the clinical effectiveness beyond the gemcit alone at a potentially acceptable cost. In 2016, ESCO gave some recommendation which were published in JCO. There were 4 categories of using SBRT in locally advanced pancreatic cancer. According to them, we can use SBRT upfront if the patient is not fit for chemotherapy or surgery. Second recommendation was for the patients who have received induction chemotherapy, but who have local progression. In the absence of distant metastasis, SBRT can be offered. Third category would be the patients where patients have received induction chemotherapy, there little or no response, but there are some side effects or toxicities because of chemotherapy, and then probably you can consider these patients for SBRT. Or fourth, when you have given chemotherapy, there are no side effects, but still you want to give a kind of a chemo break. At that time, you can consider giving SBRT. Talking of the contraindication, so SBRT ideally should be avoided if there is a direct invasion of the bowel or the stomach on CT, MRI, or endoscopy. So coming on to the challenges for SBRT in pancreas. So most of the tumors, they are present in the head of the pancreas, and it lies in close proximity to the C loop of the duodenum. So we can think of SBRT only if it is not infiltrating the duodenum. By the time it is not infiltrated, we can still consider giving SBRT. But still, this even if it is not infiltrating, it lies very close to our high dose target and has to be avoided. When we deliver conventionally fractionated radiation, there are a lot of small bowel issues such as ulceration, stenosis, bleeding, and perforation. Pancreas moves with respiration as well as with peristalsis, and this is not predictable. So this is the motion which we usually see in every patient. And when we are treating with conventional fractionation, conventional fractionated radiation, this motion is not a big issue for us because we can give a margin. But when we are giving a very high dose, we cannot expand our margin, because expanding our margin for this motion eventually means more volume or more irradiated extra volume of high dose radiation, and eventually which will have more complications. So when we are doing SBRT simulation, there are a few things we have to keep in mind. The ideal way is to implant 3 to 5 fiducial markers at the tumor site. This can be done endoscopically and should be done at least 2 to 3 weeks before a planned SBRT, so that we can, this is to locate the tumor when we are treating it. So this is the, in fact, there are studies where they have compared fiducial markers with the stent. You can use stent also as a surrogate when because there should be something which soft tissues, unless you are having equipments which can very well show you the soft tissues, it is good. But if you are having some equipments which cannot differentiate between soft tissues very well, they cannot define it very well. So these surrogates like gold fiducials or the stents, they play a very important role. Next is the motion management, which as I showed just now, that motion management is very important. Pancreas and the abdominal structures, they move a lot during respiration, and you cannot uh, do SBRT if you are not addressing that motion. Immobilization is very important. Again, if the target is moving continuously and you have not counteracted for that motion, you cannot deliver a high dose. So this is the kind of high dose we usually expect in an SBRT versus what we usually see in our conventional radiation. These are the various equipments, the machines. All these machines are capable of doing SBRT. Every machine has its own pros and cons. It depends on the kind of setup you are working with. Respiratory gating is very important. If you're having it, you are having an extra edge because you can now account for respiration, and accordingly you can minimize your radiation margin and eventually your radiation volume. So to conclude, SBRT can be considered an effective and safe therapeutic option in the management of unresectable locally advanced pancreatic cancers. In contrast to conventional radiation, it can save a lot of precious time at the time. Same time, we can provide a high tumoricidal dose. Pancreatic SBRT remains an exciting field for further investigation, and as more clinical evidence becomes available, its efficacy and safety will be further improved. Thank you.
Thank you, Dr. Samir, for a nice elaborative talk. A lot of things went over my head. I have a question before we move on to medical oncology session. Uh, we, as a medical oncologist, it's very clear to me that if somebody has to get radiation for pancreatic cancer, it has to be SBRT because that saves a lot of time, what we use for
Absolutely.
6 weeks of conventional.
Absolutely.
Why there is no randomized study yet to prove it that SBRT is new standard? Whenever we talk to Americans, they still believe conventional long fraction RT to be still standard for locally advanced pancreatic cancer. Why do you think it is the case?
I guess what I understand, there will be, I'm sure there are studies underway which are comparing SBRT versus conventional fractionation. But even in our clinical practice, we have seen many patients who present with some kind of infiltration of the bowel or stomach. So if you're having that clinical picture, anyways, you cannot consider that patient for SBRT. Probably that can be one of the reason. Otherwise, I do not see any reason. SBRT should be the standard of care unless there is any bowel, this small bowel or the stomach infiltration.
And one more question. Let's say if Dr. Dhaval and Dr. Nitin are with us, if they want to operate a case of borderline resectable patient, would you do SBRT or would you do long fraction RT?
I would definitely do SBRT. In fact, any of my for me pancreas cancer, I would always consider SBRT unless there is bowel infiltration, whether it is
Excellent.
adjuvant, neoadjuvant, resectable, borderline, or locally advanced.
That is a very crisp message, I think so. That unless you have a bowel infiltration, if you want to radiate a pancreas, it has to be SBRT.
It has to be SBRT.
Fantastic take-home message. Thank you, Dr. Samir.
Thank you.
Thank you. Okay, let's move on to the next session. Now onwards, we'll have more of medical oncology. So now I will invite Dr. Ashish Kaushal. He's head of medical oncology at HCG Cancer Center and my friendly boss. And he's going to talk on PARP inhibitors for metastatic pancreatic cancer or maintenance pancreatic cancer. Sir, screen's yours.
Yeah, thank you. Thanks, Viraj. May I audible?
Yes.
Yeah, thank you. So I think this is a AstraZeneca sponsored symposium. So I'm going to share with some of the newer things which comes in the pancreatic cancer management, the role of BRCA and PARP inhibitor in metastatic pancreatic cancer. So these are my agenda. I'm going to discuss about the BRCA and pancreatic cancer and the POLO trial. We all know the pancreatic cancer is one of the notorious cancer, and approximately 500,000 of the new cases of pancreatic cancer diagnosed almost every year. And this prevalence is more common in the developed country compared to our countries. And the annual incidence is approximately 2.5% compared to the rest of the cancers. If you see the overall outcome of the pancreatic cancer, we have been already discussed with the surgical colleagues and the radiation colleagues. The pancreatic cancer is a very aggressive disease, and majority of the patient is a very poor prognosis. The reason most of the patient diagnosed at advanced stage, and even with the early stage, we can consider altogether. I think the 1 year survival is around 20 to 35%, depends on the area of the treatment. And US, even the 5 year survival is just less than 10%. So this note, I think we see there is a very less improvement in the survival in the pancreatic cancer in last 4 decades, especially in 1970s to 2011. And the 1 in 5 year survival still is not that optimal even as of now. If you see the treatment option, even the progression-free survival with the current options is not that great. So there is a significant unmet need for the newer therapies. With a single drug of the 5-FU, the benefit is 1 month. Gemcitabine gives another 3.5 months. With the combination of gemcitabine and paclitaxel is around 5.5 months, and with combination of 3 drugs, FOLFIRINOX, we have around 6.5 months. So this is the standard treatment option as of now. And if we look for the newer molecular testing, especially the BRCA, and approximately around 5 to 7% of the all patient of the pancreatic cancer is a germline BRCA mutation. That means around out of 15, 1 patient having germline BRCA. And if we see out of 2 common BRCA mutation, BRCA2 is more common than BRCA1. The ratio is BRCA1 to 2 is 1:3. And these mutations are increased, especially in some of the ethnic groups and the patients that is family history of these mutations. So there are the data where the addition of the platinum-based treatment, they improve the survival of BRCA mutation patient, and this overall survival in BRCA mutation, especially in germline BRCA and stage 4, with the addition of the platinum-based treatment is double, and particularly the patient who are HR mutated advanced pancreatic cancer, the addition of the platinum is triple the overall survival. So that's the benefit of doing this test. Coming to the POLO trial, the POLO is the first randomized trial. It's a phase 3 trial which investigate the role of the PARP inhibitor in germline BRCA mutated pancreatic cancer. It's a double-blind study. And these are the patient population who was initially treated with the first-line platinum-based treatment. And these are the patients who are not progressed. Either they have a response or they have a stable disease. And these patients are included for this study. So the primary patient population are the metastatic pancreatic adenocarcinoma, with this patient having a germline BRCA mutation with a good performance status. And one of the major important criteria, these are the patient at least received the 16th week of the first-line platinum-based chemotherapy, and there should not be any evidence of the disease progression. There is no limit of the duration of the chemotherapy, but 16 weeks of the minimal treatment is required. And the patient should not have any grade 2 or more toxicity from the current therapy, excepting alopecia or grade 3 peripheral neuropathy. This randomization was done as 3:2. The olaparib was given in 300 milligram twice in a daily versus placebo, and these are the patients who been further observed for their response based on the progression-free survival, and the secondary endpoint is overall survival, PFS2, time for first subsequent treatment, time for second subsequent treatment, overall response rate, disease control rate, and health-related quality of life issues as well as the safety issues. So this POLO is actually provided the most comprehensive database for the germline BRCA mutation in pancreatic cancer. And in this study, approximately 2,200 patients have been screened. And with this, they have found approximately the overall mutation rate around 7.4%. The 7.2% patient is having the germline BRCA mutation. 6% patient is the newly identified germline BRCA, and around 5.1% patient is the newly identified BRCA, excluding from other countries like US and Israel. So these are the patients which they start their recruitment from Jan 2015 till the Jan 2019, approximately the 4 years. And the primary event was achieved on the basis of PFS rate per patient by blinded independent central review. And OS event achieves around 71 OS survival events. So if you see this data of this BRCA versus placebo and the patient in the maintenance arm, the most common reason for discontinuation was the disease progression. And this study is going on, the data is captured is going on. Approximately 30% of the olaparib patients are still ongoing study compared to the placebo, around 12.9% patient on the placebo as of now. If you see the baseline characteristic in both the arms, it's quite balanced based on the median age, which is approximately 57 years of both the arms, along with the sex, the status of the BRCA mutation, whether it is a BRCA1 and 2, ECOG performance status, and the duration of the first-line treatment, whether this treatment given from 16 weeks to 6 months or more than 6 months. So everything has been nicely balanced in both arms. If you see, the most common side of the metastasis was liver. Besides that, lung, peritoneum, and other disease, and some of the patient stenting was also done. So this was actually nicely balanced. And if you see the prior treatment history, like FOLFIRINOX was the most common regimen as a first-line treatment, which was given approximately 1/3 of the patient or more than 6 month duration. And after that, there are other regimen like GemCis and other combination. And whether it is doublet and triplets, it's been balanced in both arms, and as well as the patient who received the response of the primary treatment, whether it's a stable disease or CRPR, they have been balanced approximately 50% in both arms. So if you see the data, first data of the PFS, the olaparib significantly improved the PFS, and it reduced the risk of progression or death by around 47% compared to the placebo. The median PFS in olaparib arm was around 7.4 months compared to the 3.8 months in the placebo arm. So the median PFS was almost double, with 95% improvement over the placebo. So that's just really significant, with the HRS 0.53. If you see the outcome of this patient in all the time points, they've been assessed, and almost twice as many as patient is progression free compared to the placebo in the olaparib arm, whether it is assessed at the 6 months, 12 months, 18 months, or 24 months. So the PFS is almost double in all the time points. And this is the diagram is showing the summary of the first-line treatment. The first line gives approximately 5 months on an average, and then after that treatment, and then there is a PFS with this drug is approximately 7.4 versus 3.8 in the placebo arm, with a significant around HRS 0.53. If you see the benefit of olaparib in all the subgroup on the basis of previous chemotherapy treatment and the duration of the treatment, the response, and whether it's the status of the BRCA or the age and sex, I think all the subgroup it shows a benefit, though polo was not that power to demonstrate the difference between the subgroups. If you see the further line of the treatment, approximately some of the patients, they received the PARP inhibitor subsequent line of treatment, and majority of the patients are the placebo, but only one patient in the olaparib arm, the PARP was given as a 5th line. So it is more in the placebo, even one patient in the olaparib arm also. And some of the patients, those who have a measurable disease at the baseline, to start with the study, and approximately 33% patient having the response in olaparib compared to 11.5% in the placebo arm. So if you see the disease control at 16 weeks, more than 50% of the patient in the olaparib arm are disease control compared to the 37% in the placebo arm. And this is the most important slides. It's a summary of the time to all the endpoints. The PFS is around 7.4 versus 3.8, favoring the olaparib with a significant HR, 0.53. We have a PFS2 data, 13.2 versus 9.2, and the OS is not that mature as of now. The HR is 0.9, 18.9 versus 18.1. As of now, it is we have a 46% maturity. So the data is still not that power to give the OS data. So there is no difference in the health-related quality of life and first data compared to the olaparib versus placebo. And if you see the global HR quality of life is over time was similar in the both the arms. But olaparib is associated with some side effects. The grade 3 adverse events occurring around 40% of patient olaparib compared to the 23% patient in the placebo. The most common side effects which was there in olaparib is the nausea, fatigue, and anemia, which is there. And but out of these all side effects, only the fatigue which resulted in treatment discontinuation is more than one patient. That is, I think, 2 patients in the olaparib arms. So that's the reason. If you see the side effects of the interest, there was no MDS AML reported in the both the arms. There was one non-serious pneumonitis in the olaparib arm. And there is a 2 patient, there is a new malignancy, like one patient is the rectal cancer in the placebo arm, and one patient is the ovarian cancer in the placebo arm. So to conclude, the POLO regimen established the new paradigm of the biomarker-driven approach in the metastatic pancreatic cancer. And these are the patients who's initially treated with the platinum-based treatment, and that olaparib significantly improved the PFS, especially in germline BRCA-mutated metastatic pancreatic cancer compared to the placebo. The median PFS was improved around 3.6 months compared to the placebo, and twice as many patients is progression-free with the olaparib treatment arm in all the time points has been assessed. Approximately 1/5 to all patients have the response with the while the olaparib maintenance. Overall data and the PFS data is not mature as of now, but still the follow-up is continuous. The global quality of the life is similar in both olaparib and the placebo arm, and this is a very tolerated regimen. So with this data, I think now we have an NCCN category 2A recommendation as of now with the olaparib maintenance of those patients who achieve CRPR or stable disease. With this, thanks to entire team. Thank you.
Thank you, sir, for a nice lecture on olaparib. Of course, we will revisit this point in a panel discussion, but let's move on to the most awaited topic for this today is the debate. And let me tell you, this is one of my favorite debate. I usually like to debate on this topic, but today I'm not the one who is going to debate. Today we have Dr. Chintan Shah and Dr. Nitin Singhal. Nitin Singhal is very close friend, and he is a fantastic GI surgeon. And of course, he is going to debate for the motion for operation first for resectable pancreatic cancer. And Chintan is also a very close friend of mine. We studied together in Hyderabad, and he is going to go against that. Even in resectable pancreatic cancer, one should go for neoadjuvant approach. So let me invite the surgeon first. As usual, the surgeon goes first. Dr. Nitin Singhal, you have 10 minutes to prove your case that for resectable pancreatic cancer, surgeon should go first. And let me tell you, it is going to be very entertaining. Nitin has a way of putting his case in a form of entertainment. But let's see, we'll have show of hands in the end to see who's where. Nitin, go ahead. Is Nitin there online, Ravindra?
Am I audible?
Yes, now you are.
Okay, and my slides are visible?
Yes, very much.
Okay.
And that is why I made a comment that it's very entertaining to listen to you always. Go ahead.
Okay, thanks for that. Okay, while I was preparing for this presentation, in these gloomy times, I came across a very, I would say, inspiring thought. I thought I'll share it with you before I start the topic. A journey of 1,000 miles must begin with a single step. I don't know who wrote it, although the name is there, but it does make a sense. So, as Viraj told you, I'll be defending for the acceptable treatment option, that is the adjuvant approach, which is as of now the standard of care. So, why are we discussing so much about this thing? See, we all know pancreatic cancer is a very common cancer, and it is one of the deadliest cancer. And it has been projected that by 2030, it will be the second most prevalent cause of death by cancer, just short of lung cancer. And we all would agree, without any debate on this, that it requires multi-modality treatment for better outcomes. When we talk about 5-year overall survival, we have seen significant improvement in all the solid tumor subset. But if we talk about pancreas cancer as a whole, then the 5-year overall survival has improved to a dismal 5 to 8%. I'm taking into account all the stages together. And what has prompted the medical oncologists to try this methodology of putting neoadjuvant therapy first is because of the success of neoadjuvant strategies in other solid tumors. And even when we talk about pancreatic cancer, in borderline resectable pancreatic cancer. So they have been encouraged by that. And let's see how they fare. So my good friend Chintan, I know when he will be speaking, he will be offering this possible theoretical advantages to defend this motion, that neoadjuvant therapy offers better R0 resections, more completion of treatment. Now, mind you, when I'm talking about completion of treatment, please remember this line. When we talk about complete treatment in pancreas, it includes both local as well as systemic treatment. And you'll also try to emphasize that chemotherapy leads to better patient selection for surgery, and early exposure of systemic therapy leads to improved survival by taking care of the micrometastasis. These are all possible theoretical advantages. They all may sound very beautiful, very attractive, and very logical. But I thought when I was thinking about it, actually, it really felt, is it really worth debating it? And then a semblance came to my mind, as you can see on your screen. This is the famous India Shining movement of 2004. I'm sorry, and I would like to put a disclaimer that I don't support any particular political party or not support any particular party, just a semblance. So this India Shining 2004 movement, if everybody remembers, it was very famous, L.K. Advani going around and saying India Shining, India Shining. And similarly, my friend would be rattling, would be saying NSCT is shining, NSCT is shining. But is NSCT really shining? And if he thinks so, then I think he's ready for this fate, what Lal Krishna Advani and BJP felt in 2004. Because by the end of my talk, I'll make sure that NSCT is not the answer to resectable pancreatic cancers. So before I go and show the evidence, let's understand what is resectable pancreatic cancer. So to put it simple, because it has been discussed previously, as per the NCCN criteria, which defined this particular thing few years back, resectable pancreatic cancer would be one which does not have any distant metastasis, and the tumor is not in proximity of major vessels, to keep it very simple. And if you go by this definition, only 10 to 20% of the patients at the time of diagnosis would fit into this group of resectable pancreatic cancer. Now, why I did this definition at the outset is because of the confusing terminology being used worldwide, and especially if I go back few years back, then there was a lot of intermixing of borderline resectable and resectable pancreatic cancers, causing a lot of problems in understanding the outcomes. Now, let's start one by one. As I said, the first of the endpoints which my good friend would be debating for against would be that neoadjuvant chemotherapy leads to more of R0 resections. Now, first, let's understand what is R0 resection. Now, R0 resection in pancreatic cancer, it's a controversial thing. Again, if we go for the literature, some studies, they say no tumor at ink margin, that is 0 mm margin, is considered as a R0 resection. Certain others take it anything less than 1 mm also as an R0 resection. Although the standard definition for the same is 1 mm, more than 1 mm definition. As you can see, there is so much of diversity in the definition itself, and there is a lot of diversity in the examination of pathological specimen. Even though we have a well-defined protocol, still it is not being uniformly followed. On top of that, there's a lot of morphological heterogeneity and dispersed tumor growth, which makes data on R0 rates from different surgical centers incomparable, and that is why it does not appear to be an appropriate endpoint. And one also needs to understand tumor necessarily does not shrink from periphery, but spot-wise. And it is rightly postulated that reduction of positive margins after NSATV may be due to reduction in density of cancer cells rather than tumor shrinkage. One thing before I progress further, one thing I forgot to tell. Now, when I'm debating, I'm mainly concentrating on neoadjuvant chemotherapy. I'm not taking into account neoadjuvant chemoradiation because that is mainly meant for borderline resectable pancreas. So I'm not using my arguments for NACTRT. It's mainly for NACP. Okay, coming back to R0 resection rates. Now, we all, although being from medical side, but we all have been trained for mathematics, and we all know some basic mathematics. So I'll give you a simple equation to solve. Let's say there are 100 people, out of which 100 to, I would say 100 to patients with the pancreatic cancer, out of which 20 do not undergo surgery, and we are left with 80. And out of 80, if you have a negative R0 margin in 80%, then what does it actually mean? It means 64 patients out of 100 actually had a negative R0 margin. So this is what the data in neoadjuvant chemotherapy trials, they do. They hide the data, and I'll be going more in details of it as we proceed further. So 64 in neoadjuvant chemotherapy, and this will be again equivalent to 64 even if you would have gone for adjuvant chemo, if you would have gone for upfront surgery and adjuvant chemotherapy. So practically neoadjuvant chemotherapy does not lead to significant improvement in R0 rates. Now coming to rate of surgical resection. Now this endpoint does not mean at all in when we are talking about resectable pancreas tumor. It is more for borderline resectable pancreas cancer. If at all, neoadjuvant chemotherapy makes certain resectable tumors unresectable due to certain tumors not responding to chemotherapy, and they progress while on chemotherapy. Also, certain people, they experience significant toxicity of neoadjuvant chemotherapy, and we have significant number of dropouts, which we'll discuss further. And also resection rate does not yield any significant core information on treatment significance. So it is not a significant parameter to be contemplated for. Now, talking about completion of treatment. Now, when we talk about completion of treatment, it can be looked at as if the glass is half empty or half full. But the reality is the glass is always full. It's half water and half air. So if we talk about upfront surgery, not all receive chemotherapy. And if we talk about neoadjuvant chemotherapy, not all will be fit or receive surgery. So whatever the approach, not all the patient will be finishing the complete treatment. As I mentioned initially itself, that is local systemic treatment. So irrespective of the approach, not all people are going to finish the treatment completely. Now, if we look at the data from various trials and various series, now it ranges from 25 to 50% for both. Whether you do upfront surgery, 25 to 50%, depending on the center, will not receive chemotherapy. And if you give neoadjuvant chemotherapy, then 25 to 50% will not undergo surgery. But to make it more uniform, let's take the data which is more recent. And as per the recent studies, that is RTOG 9704 and ASPECT-3, 90% of the patients in the trial, they received the prescribed adjuvant therapy following surgery. That means only 10% could not finish it. And to compare it, the MD Anderson data, which propagates neoadjuvant approach, approximately 20% of the patient in their population could not, who are potentially resectable, did not undergo surgery after the planned NACT. So the numbers are in front of you. So you can make a clear choice that yes, the data which says the medical oncologists, they try to say that surgery first will make many patients not receiving chemotherapy is not true. Now, going for some more evidence, looking at the data, neoadjuvant therapy trial data. Now, mind you, most of these trials, these are small series studies, retrospective data, and you see most of the information, it is not available. And again, my point, you can see the dropout rates, they are significant. R0 resections, as I mentioned, they are the same. And when you talk about survival, just have a look. It is 26.4 months in one study and 17 months. Now compare this with the data on adjuvant therapy. Now this bottommost, this Oetel et al. Is the first study for adjuvant therapy, that is a CONCO 01 study. In that too, which actually set the standard of care in pancreatic resectable cancer, surgery followed by adjuvant chemotherapy. In that too, the survival was almost equal or slightly more than what is being shown in that neoadjuvant therapy trial study. And if you see the recent trials, this one, which my dear friend Viraj also likes a lot, Folfirinox et al. This is the Prodigy 24 trial. In this, the survival has been shown to be as high as 54.4 months. And then there are certain other studies, NEP-PACLI studies, which have shown the survival to the tune of 3.5, 4 years. So with better chemotherapies and even aspect-4, let's not go that far, aspect-4 also, when they combine capecitabine along with gemcitabine, the survival is significantly higher. So if you look at the modern trials of adjuvant chemotherapy, the survivors have improved significantly. So the argument that only neoadjuvant chemotherapy can improve survival does not hold true. Adjuvant therapy is showing improvement in survival, and it is basically the drugs which have come into the market who are better tolerated and who better target these cancers have led to this improvement in survival. Also, if you see the R0 resection rates in the recent studies, these have improved. This is again due to the better, I would say, the understanding of the anatomy, the better dissection techniques of the surgeon, and better imaging which we have, all leading to a better resection rates and also the better definition of this resectable pancreatic tumors. All this have led to a better outcomes. Now, again, coming back to interpreting the NACT evidence. Now, whenever you are interpreting the NACT evidence, please interpret it with a pinch of salt, as it has a lot of selection bias. Majority of evidence is retrospective from small series, and we don't have data from well-designed RCT. Many of these earlier series have clubbed borderline resectable pancreatic cancers along with it due to the ambiguity of definition as we discussed previously, and leading to false large number of R1 dissections upfront surgery group. Also, there is no explicit data for tumor being subdivided into anatomical subregions such as head, body, or tail. All pancreatic tumors have been clubbed as pancreatic tumors. They have not subdivided it into further. Also, now coming back to the first point which I mentioned, selection bias, and which has skewed the numbers in favors of NACT, of which the most important mentioning is the trial by Mogdad et al., which used the data from National Cancer Database of around 15,000 odd patients from 2006 to 2012, and which compared the outcomes of primary resection and neoadjuvant therapy in pancreatic adenocarcinoma stage 1 and 2 patients. And this trial obviously favored neoadjuvant chemotherapy, but one important limitation of this study was that only patients who had undergone curative intent resections were included in the analysis. So what exactly I mean is the people who underwent neoadjuvant chemotherapy and who subsequently did not undergo surgery, that is dropout from neoadjuvant chemotherapy, were excluded from the analysis. So we chose the apples, we chose the better apples, and we chose the best apples. So obviously if you are choosing the best apples, you cannot compare it with just the apples. So that is how this trials are so skewed in favor of NACT. And if you go into literature, this number can be as high as to the rate of 18 to 42%. So if you're not using the data of this 18 to 42%, if you're hiding this data, then obviously the data which you're getting is not the correct data. Now, okay. I don't know, one slide actually went missing.
Nitin, I think the time's up. Can we wrap up?
Yeah, just just two more things. One, if most of the data for neoadjuvant chemotherapy is in the form of meta-analysis and systemic reviews. Now, when we talk about meta-analysis and systemic reviews, most of them have not used intention to treat analysis, and they have used per protocol analysis, again skewing the data in favor of NACT. And one of the few reviews which have actually used this intention to treat analysis, they actually show that neoadjuvant chemotherapy does not do better than adjuvant chemotherapy. Now, one adherent problem with response to NACT is there is no significant way that we can assess response to neoadjuvant chemotherapy. Radiographic downstaging, as seen with other tumors, is not very much apparent with pancreatic tumors and does not correlate with survival. Also, response to neoadjuvant chemotherapy other than PAT-CR does not correlate with survival. And the PAT-CR rates which we see are very, very dismal, just 2.5% compared to other tumors. Now, other problem with this thing is argument which my friend would be giving is that going upfront surgery can lead to delay in adjuvant treatment. But trials have shown that even a delay of up to 12 weeks does not alter outcome at all. There is a retrospective data of aspect 3 which has shown that chemo given after 12 weeks also does not affect survival at all. And there are some certain other problems with neoadjuvant treatment, that patients who undergo neoadjuvant treatment, they require biopsy. And around 20 to 30% of this patient may require re-biopsy because the US guided FNAB techniques might not be sufficient enough to target the sites, and the tissue which we get may not be sufficient for new generation sequencing, which may be the standard of care as Sir showed in the previous presentation. And many of these patients, they actually require biliary stenting and dose reduction because these are jaundice patients, and also they have chemotoxicity. So in nutshell, what the guidelines say, the guidelines rightly on the basis of evidence, they say in resectable pancreatic cancer, surgery followed by adjuvant chemotherapy is the standard of care. Now coming back to the same thought, a journey of 1,000 miles must begin with the single right step. I've just modified this, and the right step in pancreatic cancer treatment for resectable pancreatic cancer is surgery. Thank you.
Thank you, Nitin. Um, as usual, dominant screen presence. Chintan, your turn to go.
Yeah. So thank you, Viraj, for giving me this opportunity. And uh, so my friend has nicely presented how upfront surgery should be the option to go. But I would like to show in my next few slides, next 10 minutes, that this is not exactly the right step. So, Nitin, can you stop sharing your slide?
I'm just stopping it.
Yeah, thank you. So, yeah. So, my slide set is visible? Yeah. So, as we know, the older computers, the left one on the picture is the oldest computer invented. Then the newer one on the right top. Then the newer one is the laptop, and now we have computers, practically speaking, in on our phone, on our in our hands. So this is how technology has evolved. The smaller ones, the newer ones are much faster, much user friendly compared to the older ones. So why is this required? When the technology has moved fast and driven the computers so small and so fast, why it shouldn't be the case in pancreatic cancers? So why do we need this? Because the 3-year survival rates with surgery alone was somewhere close to 20% in resectable pancreatic cancers. Surgery and adding adjuvant chemotherapy increased that to 30 to 60% depending on the chemo regime used. So what about neoadjuvant chemo and surgery? So let's see in the next few slides. So what's the problem with surgery first? My friend has already discussed some of the points, but he missed on this, that resectable tumors are not all actually resectable. So this is a paper recently published, the SWOG S1505, where neoadjuvant 2 different regimens were compared. And if you go through the line, that baseline just below the schema, trial schema, is the baseline scans underwent retrospective central radiology review for eligibility, determined that 44 out of 147 enrolled patients were ineligible for the trial. So here, those patients who were considered eligible as resectable, they were reviewed by a central radiology committee, and they found that nearly 30%, one third, 1 out of 3 patients was not actually a resectable pancreatic cancer. So there is a lot of bias involved in selection of resectable cases. So we don't know actually who actually are resectable and who are not resectable. So this was because many of those 30% patients had either venous or arterial invasion, and some also had a distant metastasis. Second point, around 20 to 40% of the patients are unable to receive adjuvant chemotherapy due to post-op complications or morbidity. This is around the various trials, across the different trials. Tolerance is a big issue in post-op setting, which I think most of my medical oncology friends and colleagues would have seen. So these are the 3 major issues of giving adjuvant chemotherapy. So what are the advantages of giving the same chemotherapy upfront? So firstly, it eliminates the possible circulating tumor cells and distant micrometastasis in the patients, reducing the risk of early post-op recurrence. And this is just not on paper. I will show you, and this is proven in a recent clinical trial as well. Secondly, shrinking the local tumors, improving the vascular invasion, and hence making the R0 resection rates better. This is again shown in the randomized trial that neoadjuvant chemo followed by surgery led to better R0 resection rate compared to upfront surgery. We'll be discussing in the next few slides. And my friend was saying that around 10 to 20% of the patients are not able to undergo surgery. This is in a way a good thing, because many of those would have progressed on neoadjuvant therapy, and it tells you about a bad biology. That is, it is biologically a very bad disease that despite giving a good chemotherapy regimen, the disease is progressing. So you are saving the patient rather from a very morbid surgery. Fourthly, that chemotherapy delivery is much more effective and efficient when the blood supply is intact to the tumor cells rather than in the post-op fibrotic tissues. So this is that randomized phase 2 and then led to a phase 3 trial of neoadjuvant chemo, where gemcitabine and S1, that is the oral capecitabine available in Japan, was used as neoadjuvant, followed by adjuvant regimen, and the second arm was surgery upfront followed by adjuvant therapy. So this is very important to note that in the neoadjuvant arm, only 2 cycles of gemcitabine plus S1 were given. There was every 21-day cycle and only 2 cycles were given. This was relatively much inadequate and very little dose of neoadjuvant chemotherapy was used. And this trial was a phase 2 and primarily they aimed at seeing the R0 resection rate. That was the primary endpoint of the phase 2 trial. And they found that it was 93% in the neoadjuvant therapy arm, while it was 82% with the upfront surgery arm. This results justified moving to a phase 3 trial with overall survival as the primary endpoint, as you can see. So this is a trial where all resectable only patients were included and there were no borderline cases in this trial. So coming to the endpoint of overall survival in the phase 3 trial, as you can clearly see the Kaplan-Meier curves, the neoadjuvant chemotherapy arm, the median overall survival was nearly 36 months compared to 26 months in the surgery upfront arm. And 2-year survival was 63 versus 52%, 11% absolute difference in overall survival when you give neoadjuvant therapy, although this was a very less dose and a weaker regime used. Despite that, we got such drastic and dramatic difference in overall survival at 2 years. So this is a very good point which I told, that it's not only the on paper thing that it kills the micrometastasis. If you see that the pattern of recurrence, liver was the only significant pattern of recurrence, where it was nearly 50% in the upfront surgery arm versus 30% in the neoadjuvant therapy arm. The p-value was quite significant. And this shows that neoadjuvant chemotherapy definitely reduces the distant metastasis rate, and it's not just on paper. And as we all know, the pancreatic cancers more oftenly relapse distally rather than loco-regionally. And hence, the neoadjuvant chemo adds to the survival benefit. So another paper which we discuss about that 1/3 of the patients were not actually resectable, that is SWOG 1505, which was recently presented in the ASCO 2020 virtual meeting. So it was more about picking the right chemo regime, either we should go with FOLFIRINOX and nab-paclitaxel. I thought my friend would also comment that there is no established regime right now. We don't know which regime to use. But this was a trial where they wanted to compare these two. It was again a phase 2 trial. They wanted to pick up which is the better regime and move on to compare the same regime in the neoadjuvant versus adjuvant fashion. But to the surprise, it was found that both the regimes were very good. The 2-year survival rate with both was close to 45%, which is quite interesting. And the median survival was close to 2 years. R0 resections were nearly 85-90% in both the regimes. And although the results were very good, the study failed to meet the primary endpoint, because the primary endpoint they took as 2-year survival rate should be at least 58% or more, which was not established with both of these regimes, because standard neoadjuvant protocol with this schedule gives a 2-year survival rate of close to 40%, which was achieved with this. But they didn't broke this benchmark of 58%, and I don't know why they kept this benchmark of 58% and so high. So the primary endpoint was not achieved, but still, we found that the 2-year survival was quite good, and both regimes were active regimes, whether you give gem-nab-paclitaxel or you give modified FOLFIRINOX. So again, this helped to know that both the regimes are working. So coming to that systemic review and meta-analysis part, I knew my friend was going to include this in one of his slides, and so the comment was that the intention to treat analysis and the per protocol analysis both were done in the systemic review and meta-analysis, but you should think and see this with caution, because majority of the papers included were either retrospective study or small cohort studies, and there were hardly any proper randomized controlled trial included. Only one trial, if I am correct, was included in this paper. So this should be taken with a pinch of salt, but still, if you go through what it says is, although Per protocol analysis showed the survival gain of neoadjuvant therapy with a hazard ratio of 0.72. Intention to treat analysis did not show the statistical significance. However, neoadjuvant therapy completed the subsequent surgery showed better survival over upfront surgery completed with adjuvant therapy. So surgery and chemo put together definitely both works better compared to only one part. So they concluded that supporting evidence of neoadjuvant therapy in resectable pancreatic cancer was insufficient because of the benefit not established in intention to treat analysis. However, among the patients who completed both surgery and chemotherapy, the neoadjuvant arm showed survival benefit over the adjuvant therapy. Therefore, neoadjuvant therapy could have a role of triaging the patients for surgery even in resectable pancreatic cancer. So again, what the guidelines is, this is a little difficult to see, but this is the algorithm from UpToDate, where again, they give both the options that whether patient wants to, you discuss the option of neoadjuvant therapy versus surgery. So that is one of the second row box you can see. So they are not ruling out neoadjuvant therapy. They don't say it's all should go for adjuvant therapy. So neoadjuvant therapy is taking a good competition and coming rather neck to adjuvant, and maybe it will win very soon. So again, if you see the algorithm of NCCN, which my friend quoted at the last, but I have circled here that most NCCN member institutions prefer neoadjuvant therapy at or according through a high volume center. They have given both the options: proceed to surgery without neoadjuvant therapy, or you give neoadjuvant therapy. But still, most of them prefer giving neoadjuvant therapy, maybe because they need still further. They are convinced with the available data, but they are trying to wait for still more robust data, which will come very soon, maybe. So the treatment completion rate, if you see across all the various trials, in adjuvant therapy ranges from somewhere around 40 to 60 or maybe 70%. While in neoadjuvant therapy, the treatment completion rate is more than 80%. R0 resection rate, again, definitely better with neoadjuvant therapy arm. The 2-year survival as seen in the recent 189 phase 2 and 3 trial was significant, and median overall survival also was significant when it was compared head to head. What my friend did was India Shining 2004, but still you can see 2014 and 2019 what has happened and who has won. Again, disclaimer, I would like to say nice, I don't support any parties, and I don't oppose any party either. So the other thing which he was stressing was that 10 to 20% could not go for surgery. I think it was good for them, and they were lucky that they did not go, because the surgery also was not going to help them, because it was really a bad biology disease. Again, what he compared in his presentation was cross comparison of trials. Comparing neoadjuvant trials with adjuvant trials is not the ideal way to decide your treatment, and cross comparison of trials can be grossly misleading. I thought he would also point on this things that it is Japanese study, it's not applicable to India or the Western world. Second point was the S1 is not available anywhere except for Japan. And he would also say that I can see all the disease and resect it, including the microscopic disease. But I think he's feeling something like this. So thank you. And that's all. Thank you.
Thank you, Chintan, for defending chemotherapy first approach. Now we ran out of time definitely with this debate. I was expecting just 10 minutes with each speaker. So I'll just give away my take home like couple of points. And of course, I'll tend to be a little bit biased because I'm a medical oncologist. But to be fair to Nitin, there are certain points in favor of surgery first in resectable pancreatic cancer. And the two most important things that I can think of is needing of a stent in case of an obstructive jaundice. Now that we know can increase the risk of cholangitis and further complications. And second is the need for the tissue diagnosis. And we all know that EUS guided biopsy is not a great way to get a yield every time. You could do it one time, you could do it 2 times. And it can only be done in the expert center where you have an on-site pathologist. When your gastroenterologist is doing EUS FNA, you need an on-site pathologist to tell you whether you got sufficient tissue or not. So I agree. There are certain points, certain technical issues with proceeding for neoadjuvant therapy, while surgery is easy, just you go in and take out what you see. But I completely agree with Chintan, and being a medical oncologist, we know that what all seems resectable is not. There are more than 25 to 30% of surprises when you open up a case of resectable pancreatic case. So it's just open and shut. And the argument what Nitin made, and which I agree with Chintan, is that in neoadjuvant series, that whatever data we have, about 20% of patients do not end up getting a surgery because they have a distant metastasis on therapy. Now, the argument surgeon makes is that you lost the opportunity of cure, while what we believe is they are bad biology and you avoided a futile surgery. So these are just two different ways to look at the same scenario. Well, I believe in the latter, where you prevented a futile surgery. Second, we have all medical oncologists here. I wanted to ask how many of you have completed 6 months of FOLFIRINOX in a patients after Whipple? And I can just count on my fingers. It's absolutely not possible. And Nitin, what you showed, that gem-nab-paclitaxel adjuvant trial was a negative study. That means the adjuvant is only better with FOLFIRINOX. Otherwise, it's just gem-cap, which is again going back to 25 months of survival. 54 months of survival of Prodige is not replicated by any other study so far. And it has a lot of questions. Even in that study, there was 60% of resection margin, only 60% R0 resection. So my take home is, if tissue diagnosis is up, and it's an institutional policy. So like MD Anderson, all pancreatic cancer go for neoadjuvant, period, done. So we are trying to build that similarly in HCG, that if possible, majority of cases would, after MDT, would go for neoadjuvant approach rather than an adjuvant approach. So Nitin, do you have any final comments before we move on to panel discussion?
So as Chintan was mentioned in the last slide, I ran out of time. I actually wanted to discuss that S1 study. So he covered that point. And coming back to, yes, as of now, I would say both the options are there, and it depends on institution to institution. But as of now, uh, except for that one Japanese trial, we don't have any strong evidence to support neoadjuvant chemotherapy. So yes, you can obviously keep it as an option, but being trained from Tata over there, we always prefer surgery first. Although now recently there is a push towards certain patients going for neoadjuvant chemotherapy, but still surgery first would be my take.
So the series presented by Dr. Srikhande from Tata Memorial Hospital suggested that in resectable, so-called resectable pancreatic case, there was 60% positive margins in the Tata series, which is considered the best place in India for Whipples. So you cannot hide that fact. That even you think it is resectable, the margins turn out positive.
So see, in Tata also have evolved.
Viraj, can I ask something?
Tata also
Yes.
have evolved.
Yes, Ami.
So what is your take on neoadjuvant chemo followed by SBRT followed by surgery in resectable patients? If I'm not wrong, even at Tata, they are doing this study in most of the resectable patients.
For resectable, I'm not sure. Borderline resectable, yes. But for resectable patients, see, adding radiation obviously will increase problems. You would also agree. As far as surgery is concerned, post-radiated tissue, obviously, if it is not similar to rectum, obviously the complication rates and all, they'll be slightly higher, and you also have more toxicities. For borderline resectable, yes, I agree with you. Because of better R0 resection possibility with radiation, because that is a local therapy which we are adding to. Yes, radiation is the way forward, but not for resectable one. And one more comment. Sorry, Viraj, I know you ran off time. One comment, you say futile surgery. Now, if you look at a different way, that 20% of the patient underwent a futile surgery, you cannot always call it futile, because many of these patients actually could have landed up with an obstructive jaundice or a gastric outlet obstruction. So even from that point of view, if you see, yes, they got the benefit of surgery. And secondly, this could be interpreted in a different way as a lead time bias. Like by giving chemotherapy and by that much of time, you detected the metastasis early in that subgroup of patients. So that is just a way of looking at it.
Okay, Nitin, point taken well. So in the interest of time, we'll move on to the last session. I think so we'll have to finish it up in 30 minutes. This is a panel discussion and I only have one slide. That's my disclaimer. And let me call quickly all my panelists. Dr. Aditi, good evening. I see you. Please,
Yes,
I
good evening.
request all my panelists to turn on their videos. Dr. Abhishek, Dr. Akash, Dr. Ekta, and Dr. Priyanka. Welcome all.
Thank you.
So many windows. All right. So, Ekta, Priyanka, Akash, can you turn on your videos so we can have interactive session? All right. So this is just one slide. I'm going to do the least talking and you five are going to do more talking. I have a list of questions with me. I'm going to ask like a schoolmaster and you guys are going to answer this. So this is a 47 male with a diffuse vague intermittent abdominal pain for last 2 months. So classic symptoms what we see for a metastatic panc. He has lost weight about 4 kilos in last 2 months. He has developed anorexia. Very recently, only for last 3 days, he is vomiting all whatever he is eating. On currently, his performance status is 2, mainly because of vomiting. And on initial exam, there is an icterus. CT scan is showing locally advanced pancreatic mass, which is encasing the major arteries and also compressing the duodenal wall from external, which is causing gastric outlet obstruction, which was causing the vomiting. And there is a moderate IHBRD. There are few suspicious liver lesions, so we did an MRI, and MRI confirmed that they were all metastatic disease. CA19-9 very high, 10,000. Biopsy was positive for moderately differentiated adenocarcinoma. Initial bilirubin was 2 on presentation. Alkaline phosphatase is more than 3 times upper limit normal. Normal enzymes, less albumin 3.2. Rest of all labs normal, no comorbidities, and no history of any malignancy in the family. So, uh, Dr. Aditi, I'll start with you. So this
Yes,
is a
sir.
patient who has what I call as a double obstruction. A single head mass obstructing the GI tract as well as obstructing the biliary tract. How do you see this often in your practice, and how do you deal with these patients?
So I usually the majority of the patients present with biliary obstruction, but minority of my cases also have gastric outlet obstruction. I usually discuss the cases with my gastroenterologist, and if endoscopic stenting is feasible in both the sites, then that is the way to go ahead according to me. Otherwise, we discuss it with the interventional radiologist for drainage of biliary system percutaneously and probably a palliative gastrojejunostomy for the GO.
Okay. So do you ever consider doing surgery, like let's say a bypass surgery for such case?
So preferably, if feasible, endoscopic stenting would be a preferred choice. But if that is not the case, patient is significantly symptomatic because of the GO, then probably palliative surgery would be given an option upfront.
Abhishek bhai, coming to you, I had a last case. What I had, this patient had an obstruction typically at duodenum level 2, second part and third part. So wherever you have to put the duodenal stent, that's an exactly the point where your scope goes in through the biliary radicals, and hence ERCP stenting is usually not possible. So I had to resort. So I didn't know how to decompress the biliary tree. How do you deal with these things in your practice?
So basically, what you try and find out is if you can do it in the safest possible way, which is as Aditi told, by doing a stenting. But the situation you described would be a tricky one because I don't think you'll be able to put in a stent, or maybe as you land up in trouble in doing the biliary stenting. In those cases, you might go for a palliative GJ. I think stage 4, 47. First thing would be to palliative before doing anything else, and the best form of the palliation would be to stop the gastric outlet obstruction. So would go for a operative bypass in this case.
Right. Akash, what about PTBD? Do you use PTBD in your practice? Like I try to do PT, so PTBD for the biliary drainage and stent for the duodenal obstruction. What do you think about that?
So PTBD is the option where means you are thinking that bilirubin is
External
around
drainage.
5 to yes external. So bilirubin is around 5 to 6, and if you feel that by giving 1 or 2 chemotherapies, your at least bilirubin obstruction will be not an issue, and you can remove it, because to continue PTBD is the difficult for quality of life for the patient. So
So
for
since
such
you
patient,
brought the level of bilirubin in this patient, would you be happy to let go the decompression and start chemo? What is your
for
comfortable
bilirubin,
level of
yes.
bilirubin?
For bilirubin, yes.
So this patient, you would go ahead with chemo without
Yes.
decompressing the biliary stream.
Biliary, yes.
Okay. Uh, Priyanka, if you have this patient, would you want to decompress the biliary tree, or this bilirubin level is okay for you? There's a lot of noise.
So if my gastroenterologist is comfortable with doing decompression with stanting, then I would like to definitely go with decompression followed by chemotherapy.
Okay. So since the scan is showing moderate IHBRD, I think so this patient is in the impending obstruction.
Obstruction.
While I completely agree with Akash that yes, one may consider. So let's say, Akash, what is your level of bilirubin? At what level you will say, no, definitely I need to decompress?
Above 3.
3.
Yes.
4. So patient has 4 then.
If only means biliary obstruction is the issue, and it's a 4, and patient performance status is good, like PS 0 or 1, I would like to start with single agent gemcitabine.
Great.
And if
what is that level where you are not comfortable?
it's not the exact level, but
exactly.
yes,
So that's my point.
5.
I
It's
wanted
above
to
5.
put this as a take-home message that there is no exact level. Abhishek bhai, let's say patient has bilirubin 19. We did a ERCP, and in just 5 days it is 9 now. You want a patient is feeling better now. Patient has stopped white stool now. Patient has started yellow stool now. Would you be tempted to start chemo, or you still want to wait 5-7 days more?
I would be tempted to start chemo.
Okay.
But technically speaking, above 5, you are in trouble. If you get in trouble, you are in trouble. So
no, I have done it. I have done it at even 10.
I was going
and
to
I'm
tell
sure
you,
everybody must have done it.
I was going to tell you that I had a patient recently who had both of these problems, and he refused for everything. And somehow I got out of it without doing anything. So we started him on chemotherapy, and he's doing well. But then in a scientific discussion, and if you don't want to get into trouble, you should be theoretically right that
no, but we want to also discuss the practical tips. So
what you can do is, as Akash said, so he is improving, he is readily getting better. Maybe you could start with the low dose gemcitabine. That would help.
Correct.
800 milligram meterscat would be good enough.
Okay. So Aditi, how do you assess nutrition? Because in pancreatic cancer, nutrition is always problem, right? Especially in India. Although I was hearing one meeting where we are seeing more and more obese pancreatic cancer, but in my clinic, I am yet to see an obese patient with pancreatic cancer. So how do you assess the nutritional status? You just eyeball them, or do you use some questionnaires? What do you use in your practice?
Usually eyeballing, sir, and the lab parameters, especially albumin levels. This is what I monitor.
So do you give albumin to them?
No, I don't give. I usually advise dietary modifications and see.
All right. So Akash, let's move on. So this patient we have decompressed. After 1 week, patient is eating well. Performance status has become 1, and bilirubin is normal, 0.9. So after 1 week, and patient is feeling very good now. What would be your preferred chemotherapy regimen in this patient, and why?
PS improves to 1, then I would like to start with FOLFIRINOX, 3 drugs.
3 drugs. What dosages do you use for FOLFIRINOX, if I may ask?
So modified only.
Like what modification? Let's say, what dose of irinotecan can you use?
Irinotecan will be 130.
Yeah.
And oxaliplatin will be in between somewhere 60 to 70 rounded up.
Excellent. Right. Absolutely. So Abhishek bhai, is that the modifications that you do as well? You cut down oxaliplatin, like I do it to 70 mg per meter square and 130 per meter square irinotecan. Do you do the same in your practice, or you go by the book and give 150 milligrams
No.
irinotecan?
In our case, 47 had a high bilirubin improving. I would take it easy.
Take it
Maybe in
easy.
the second, third dose, I would go back to the full dose, but I would start with a 25% dose reduction, as is in the case of modified. Maybe even a rounded off flat dose in the initial dose, and maybe in the next cycle you go back to the full dose, because he has just come out of a lot of trouble.
Right.
Starting with a full dose would be big problem.
Priyanka, I wanted to ask, as a medical oncologist, we always like FOLFIRINOX. Do we have a data in metastatic pancreatic case saying that FOLFIRINOX is better than a gemcitabine doublet?
So we don't have any randomized controlled trial that suggests that FOLFIRINOX is better than NAB-GEM in metastatic setting, definitely. But because he is 47 with good performance status with symptomatic patients, so of course we want good response, and there are data in adjuvant setting. We have a very good data for FOLFIRINOX. So yes, we tend to use towards like FOLFIRINOX in young fit patients. We always like to start with 3 drugs.
All right. Okay. So that is the point I wanted to drive. We don't have a randomized data suggesting one is better than the other, but we have a good 1,000 patient data suggesting that retrospective data that in metastatic pancreatic case, FOLFIRINOX may be slightly better than gemcitabine doublet. Aditi, let me come to you. Let's say you do.
Viraj,
Yes.
I think you should ask somebody to stop. I can hardly hear you.
I
Because
think so.
there's a lot
Priyanka,
of
you
noise.
have a background noise.
No, no.
Yes. Please mute yourself.
Sorry.
Please mute.
We are much better.
Ekta, are you there with us?
Yes, Viraj.
Okay, so let me come to you. We've done 8 cycles. That means 4 months of FOLFIRINOX. What do you do then? Do you continue? And patient is doing well. Patient has no neuropathy. What do you do? I find this myself in this position. After 4 months, patient is doing well. What do you do?
Though patient does not have the symptoms of neuropathy, but if we continue oxaliplatin, then he may develop in future. We can, though there are no strong data, but we can stop oxaliplating and continue with 5FU LV as a maintenance
Only
treatment.
5FU or FOLFIRI?
FOLFIRI, both the options are there. We can also continue FOLFIRI in this patient.
Prakash, what would you do? Would you want? Will you be tempted to continue full FOLFOXIRI? Let me ask you, what's the maximum number of FOLFOXIRI you have given in your practice? You and then Abhishek bhai, how many cycles? Then I'll tell mine.
We do 3 to 4 months only.
Okay, 4 months. And then what do you do?
Then FOLFIRI.
Okay, even though patient is responding and no neuropathy?
For them only. For them only.
Okay. Because so in those patients, if you recollect, have you encountered, because I have encountered, the moment you take off oxaliplatin, again, the CA19-9 starts to rise back. And then when you try to reintroduce oxaliplatin, the benefit is gone. The bus has been lost. Have you faced that?
No, that is actually biology. Even if you would have continued oxaliplatin, that is the PFS1. If you would have continued that, but for remaining life, I don't want neurotoxicity. That you don't.
Fair point.
You can't consider that one patient, but if you continue for 10 patients, at least 5 to 6 patients for remaining 6 to 8 or 9 months, they will continue with the neuropathy, even if means they take treatment or they don't take treatment.
Abhishek bhai, what is your threshold? How much FOLFIRINOX?
So just to go back to the previous point you were asking, Ekta, if I was given a choice, I would first do a complete panel of mutation, and then I would choose platinum, probably your FOLFIRINOX. and I would be much comfortable with the GEM nab-pacli because I feel they are both the same practically.
I didn't get you. What panel would you do?
Entire mutation panel would comprise of everything. You have
NGS.
thousands of mutations. NGS probably at least BRCA. So if you are a BRCA, and the second question you are asking, so you had a very good response and you felt that oxaliplatin, you removed oxaliplatin. So probably these are your patients who were responding well to the platinum. And so if I had a choice, would do BRCA and then choose FOLFIRINOX. Otherwise, I'm more comfortable with GEM nab-pacli. And as far as using continuous dosing is, I think 6 is good for me. 6 months is more than enough. Most of our patients I tend to put them on oral capecitabine if they are in good performance status, or I would give them a break.
So going with your philosophy, every patient should get a BRCA testing day 1?
I think every patient in pancreatic cancer, irrespective of even the resectable ones, should have a mutation analysis done. That is the rule of the day. That is another thing we don't do it in clinical practice.
No, it's excellent point because now we have a very cheap BRCA testing available.
Exactly.
I have started doing it for all my metastatic cases.
And
what you are, what you were referring to is the memorial study GEMCIS plus or minus veliparib for BRCA patients having 60% of overall response rate. So even I have started, if patient has BRCA positivity, you tend to use platinum definitely, either FOLFIRINOX or gemcitabine with cisplatin. Okay, let's move on to gemcitabine nab-paclitaxel. Aditi, what is, so I'm sure everybody uses that. What is your schedule use? Is it weekly? Is it 2 weekly? Is it, how do you use?
If a patient's performance status is excellent, sir, I still go by textbook, give day 1, 8, 15. And
Day
if
1,
on
8,
the 8, 15 every 28 days, and if over the line I feel there is tolerance issue, I go to bi-weekly schedule.
Excellent. Do we have any data suggesting that if you skip the day 8, you would hamper the efficacy?
Sir, bi-weekly data is good enough for me to continue upfront also, but but still
excellent point.
Yeah.
Abhishek bhai, what is the dose of nab-pacli you use for these patients?
So
an honest answer or not a textbook answer?
Textbook answer, you forget it. I generally, it's if I start with 100 milligram
flat dose
on flat dose on
excellent.
First couple of weeks it would be 100 and 1400 to be honest with you.
Excellent
And
point.
maybe from the third week onwards it would be 200, or sometimes many a times what I do is 100 200 for the first cycle, and then if he tolerates then it would be the usual 200, because even if you consider an average BSA of 1.5, the dose comes out to be 200.
Correct.
But 200 on day 1, I have burnt my fingers a number of times with the full dose of gem. So
Correct.
it's 100 maybe then 200.
Akash,
I always go
slow.
I always go slow.
I also do like that, and I've heard many people, going down nab-pacli at 70 per meter square. In fact, just 100 mg flat dose. Or you want to, stick to textbook of 125 per meter square. What do you do, Akash?
Mostly start with the 100 milligram flat.
100 flat dose.
100 and 1400.
And is it 1/8/15 or bi-weekly?
No, it's if 1/8/15 is possible. Otherwise, day 1/8 21 days cycle.
Oh, day 1/8 and 21 days cycle. Correct. So that is typically even what happens to my patients. We start with 1/8/15, then the cytopenias start, then we do 1/8/21, then cytopenias increase, then you do 1/15, and I'm sure everybody must be doing that ways. Couple of points. Do you use Akash GCSF as a routine practice on day 1, 8, or 15 prophylaxis?
No.
No. And what about how often do you encounter thrombocytopenia?
Usually, it starts from the 3rd month when continuous gemcitabine is used. So usually after 3rd month, it's a problem that always they range from 80,000, 90,000. Like
so what do you do then? You delay?
Wait. Means it's a for day 1, it should be 1 lakh. For day 8, 15, above 75,000, it's okay.
Okay. Abhishek bhai, do you have any secret recipe how to deal with thrombocytopenia? Like I wanted to ask, do you use romiplastim or L-Thrombopag to use prophylaxis?
No. GCSF, yes. But not tomiplastin.
There
Frankly
is
speaking,
a very nice study for
I know.
GI cancers from Memorial.
I know.
Aditi, what do you do? Do you do that? Because I do it. Disclaimer, I do it.
I give GCSF, sir. I have not used TPO.
Not a TPO. So, like Akash, what you said, from second or third month, thrombocytopenia is a hassle. And what I found, of course, there's no randomized study to prove my point. But what I have been doing is once every 15 days, I put romiplastin 250 just along with the chemo, and that maintains your platelets above 80, 90, 80, 90, and you are able to deliver them on time. But I agree, there is no randomized study, and more people are studying this. So Abhishek bhai, you brought out the point of BRCA. Just last few points before we end this. Do you also believe in doing MSI testing for pancreatic cancer? All pancreatic cancer?
I think all GI cancers.
All GI cancer. Do
So
you do
we have. If I had a choice, I would do it. But fortunately, don't have that kind of patience you have. So, so I would. So if you are going to treat metastatic cases and you have a flat recommendation of Keytruda for MMR or high MSI tumors, then you'll have to do it.
So let's say this patient has MSI high day one. What will you do?
Not day one. Maybe in the second line, I could use Keytruda.
Second line Keytruda. Anybody in my panel want to use Keytruda first line MMR?
Yes, first line.
First line. So Akash just wanted to bring that point in more in detail. MSI high Keytruda for pancreatic cancer was not so encouraging, if I remember the cohort of pancreas. Unlike other GI cancers, where the response rate is 75-80%. For pancreas is barely 40-50%. So would you be willing to let go of your standard chemotherapy and go with Keytruda first line? Just asking, there's no evidence. Just asking your opinion.
But I would that is the response rate with your chemotherapy too.
Correct. Okay. Fair point. Last point, has anybody used PARP inhibitors for any biliary tract malignancies? I know everybody must have used for ovarian. Akash, can you share your experience?
Yet not.
Yet not. Okay. Abhishek bhai?
No, I don't think so.
Okay. Okay. So it's difficult. Ashish sir brought out the lecture that for bringing out 150 patients, they had to screen 3,000 patients for BRCA. So I'm sure everybody in our lifetimes will not see more than 5 BRCA pancreatic cases. That's what I think.
I think you have to do that entire panel just like ovary. It probably works in others also. This was purely BRCA. They had done the they had done it for purely germline BRCA. So you could just like ovary probably next year treating it for you may be giving it maintenance, doing it in every cancer.
Right.
Every pancreatic cancer. And I think the sequence, what would be important in the future would be how do you sequence these treatments? It's going to be molecular oncology. You need to sequence this properly. You might use your Keytruda, I don't know, upfront, no. Probably your FOLFIRINOX, maybe maintenance with 5FU, maybe maintenance with PARP, maybe follow up with relapse. You give the second best option, GemNab, and then maybe follow it up with Keytruda. So you sequence it and you achieve 3 years. That is what I think Ashish bhai also told. You had a better PFS, not the OS, but that was purely because of sequencing. If you don't sequence it that way, you'll still land up with 12 months only.
Agreed, Abhishek bhai, agreed. So I have very recently started 2 patients on olaparib, and I yet to have to do their first scans. Hopefully, I'll be able to tell you what is the what's your Akash? What's your experience for ovarian cancer? Since I don't know how is to use olaparib, can you shed light? Like, is it a toxic drug to use, or it's a very doctor-friendly drug and patient-friendly drug?
Not actually patient-friendly drug. It's too much fatigue is there, especially most of the patients are above 60, so ovary is the issue. And anemia and other myelosuppression means one of my patient is going, so HB will be like 6 to 7. And that also will increase the fatigue. And platelets are around playing in between 50 to 60,000. and so you reduce the dose below the what they have mentioned. So that is the issue. So it's not a very easy drug like our CDK4/6 inhibitors.
Right. Priyanka, do you have any experience with olaparib in women cancer?
No.
Any separate toxicity, any other toxicity one might think of? Because it's very new for me, and I often have to ask Mansi that what I'm supposed to expect next.
So we have like given olaparib. Dr. Mansi must have, I have not given, but she has given it to one or two patients, and we have seen anemia as the commonest
Anemia is a
toxicity.
problem.
That patient, one patient required transfusion for that.
Oh, really?
To maintain, yeah. So anemia, she encountered anemia. Like we encountered anemia in one patient, and of course, which is a reported side effect.
Okay, Abhishek bhai, what about I was just reading, it's a theoretical discussion. There is a risk of leukemia as well
Yes, there is.
with
No,
PARP as well.
anybody is having patient with 300 milligram BD.
So I was
Anybody is
just
having.
to
So
summarize. I
right
don't know.
now I have started 300 BD Akash with two patients.
So
I
Okay,
don't know
so
what will happen to
how?
them. So,
Yeah.
so
Okay.
it's one is just last week, and other one has completed 2 months. So he's due for next scan. He had no problem, but the lady has started just last week.
So you should probably ask Dr. Chirag Desai to take a lecture on PARP inhibitors. He has a trial, and I don't know, he must be seeing 15-20 patients of PARP inhibitors. So
Okay.
you should be asking him to take a lecture on real life experience with PARP inhibitors.
All
Because
right.
I think he's doing a trial for PARP inhibitors in ovarian cancers as maintenance, and there are quite a few patients of that.
First line?
So I think metastatic or recurrence.
Recurrent setting.
I don't think it is first line. Yeah. So platinum sensitive recurrence. Yeah, platinum sensitive and recurrence. So he has quite a few patients. Maybe he can help. It's not easy to tolerate. That is all I can tell you from what I can see around in Vedar. But then patients are doing well, and you need those modifications, and he's doing them. So they probably you should put one lecture next time as to real life.
Aditi, I think the ovarian cancer data is so tempting, while pancreatic cancer data is not so tempting. Although we have AstraZeneca people hearing us, but what are your thoughts on that? I was not like excited. Wow, Polo one it's nowhere near the Solo one. So what are your thoughts on that? Why do you think in GI PARP is not that great, while in ovary it is amazing? I think even in breast it is not that great. What are your
Probably the
thoughts?
biology is different. The mutational burden is so less. Overall, the way genetic tests have shown multiple mutations have been picked up in other solid tumors. For pancreas, we have seen that somewhere around 10 to 20% of the cases may be positive, but the targetable mutations have remained low. So I feel that overall the disease is a little bit difficult to treat as compared to the other solid tumors, and so the responses.
Okay, so with that, let us end today's session. Does anybody have a final comment before we wrap it up?
So there's a lot of things. I'll add spice to what Priyanka said. I think this ASCO, you must have read it. There was a very nice article suggesting that PARP inhibitors were making more tumors MSI high, and adding immunotherapy together with the BRCA inhibitors was one of the ways of improving the outcome of these cancers, bad cancers. You read that article?
In GI cancers?
Yeah. I think it was in this ASCO. So what they suggested is that using these inhibitors was making these tumors more unstable. And that instability reflected in more deficient MMR or MSI high.
Okay.
And that is where your immunotherapy works. Or we're making them more susceptible to your immunotherapy drugs.
Okay.
So you never know. It might be a cocktail next time.
Sure.
Next December, you will find a cocktail of Keytruda with olaparib.
Yeah, very much possible. Okay, with that, I thank all of my wonderful panelists. Thank you all. You were great. We had a fantastic discussion. With that, let us end today's session. And just a reminder, the final part of a look back series that's on head and neck cancer. That is tomorrow, led by Dr. Ashish Kaushal. I invite you all again there. So until then, see you all. Good night. Have a great weekend.
Good night.
Thank you. Good night.